hematology, oncology, pathology, macrocytic anemias. All right, guys, so for macrocytic anemias, the first thing that we're going to be looking at, once again, is going to be the MCV. But this time, we're going to be looking for MCVs greater than 100, okay? Now, macrocytic anemia, the presentation is going to be a megaloblastic anemia. It's the same thing. Megaloblastic and macrocytic anemias are essentially the same thing. And all that it is that you're going to have larger than normal red blood cells. And this is normally due to the fact that you have impaired DNA synthesis. There's so many different types of causes, but the most common ones that we need to understand are vitamin B12 deficiency and vitamin B9 deficiency, also known as folate deficiency. Medications can cause megaloblastic anemia known as hydroxyurea, phenytoin, metformin, methotrexate, or sulfa drugs. But once again, what I want you to keep in the front of your mind is that vitamin B12 and vitamin B9 folate deficiencies are really the most common causes that we need to understand for megaloblastic macrocytic anemias. Now, before we get into it, what we're going to be seeing on peripheral blood smear, our findings are going to show red blood cells that are macrocytosis, okay, so enlarged red blood cells. And we're also going to be seeing hypersegmented neutrophils. That's very, very high yield association with macrocytic anemia, is that we're going to have more than 5 lobes of nuclear lobes in neutrophils, because we know that our neutrophils are multilobulated. And so if we're going to have megaloblastic anemia, it's also going to present with hypersegmented neutrophils. So multiple lobes of the nucleus are going to be present in the neutrophil, and you'll see that on the peripheral blood smear, and they love to show that. Now, before we get into the folate deficiency or B12 deficiencies, we have to understand the process in which we create B9 and B12. Now, the first thing that we have to understand is that we have B9 existing in our body bound to a methyl. Okay, so we have a methyl group bound to tetrahydrofolate, which is also known as B9. And so when B9 wants to get involved in DNA synthesis, because we need B9 to create DNA, it has to get rid of that methyl. So it's going to pass that methyl group to B12. So now we have a free tetrahydrofolate, which is also B9, and it can be shunted into the pathway to create DNA. Okay, but now we have a methyl bound to B12, and B12 is also needed to form DNA synthesis. So B12 has to pass its methyl group to homocysteine in order to create methionine, our amino acid. Okay, so that whole entire passing methyls is really, really important for us to understand. So first, it starts off with folate bound to a methyl group, and then that methyl is passed on to B12, and then B12 passes its methyl to homocysteine, which forms methionine. Okay, that's a really important aspect of this. So let's begin with folate deficiency. One of the main causes of folate deficiency is malnutrition. Okay, so chronic alcohol abuse or overuse is really important to understand for that. But another thing that they might ask could be the usage of methotrexate, right? Or, malabsorption. Now, what are the findings that we're going to be seeing for folate deficiency? The number one thing they like to ask is that we have increase in homocysteine, right? And that makes sense because if we were going back to our passing methyl diagram, we see that since we can't have folate pass its methyl to B12 and B12 hence can't pass the methyl to homocysteine to create methionine, we're going to have a buildup of homocysteine. And this is bad because an increase in homocysteine leads to an increased risk of thrombosis, okay? But something special about folate deficiency is that we're going to have normal methylmalonic acid. There's no neurological symptoms associated with folate deficiency, B9 deficiency. Okay, and the reason behind that is because it goes back to biochemistry. We have no need for B9 in order to break down methylmalonic acid. However, once we contrast that with B12, we're going to see a difference. So just overall view, B9 deficiency, also known as folate deficiency, has an increase in homocysteine, has normal methylmalonic acid, and no neurological symptoms. Now, B9 quickly is absorbed in the jejunum, okay? And it depletes rather quickly because we have minimal body storage of our B9, okay? So we're going to see a quick onset of B9 deficiency when someone has malnutrition. And let's compare and contrast this now to vitamin B12 deficiency. Vitamin B12 is also known as cobalamin, so cobalamin deficiency. Now, there's many different causes, known as pernicious anemia is one, malabsorption another, pancreatic insufficiency, and veganism. Veganism is something that they love to talk about for a patient. Now, comparing and contrasting it to folate deficiency, B12 deficiency takes a very, very long time because we have a lot of storage in our liver of B12. So it takes about 5 years for us to completely deplete our B12 storages if we're not actually intaking it correctly. Contrast that to B9, remember, it depletes rather quickly. However, B12 is going to have increase in methylmalonic acid. And that's going to give us our neurological symptoms that we see with the B12 deficiency compared to no neurological symptoms in folate deficiency. Okay? So the reason we have neurological symptoms in B12 is because we have increased methylmalonic acid. Also, not to mention, similarly to folate deficiency, we also have an increase in homocysteine seen in vitamin B12 deficiency. Now, these neurological symptoms, it can cause dementia, it can cause subacute combined degeneration, but what the patient's normally going to present with is just poor proprioception, decreased vibration sensation, and spastic paresis, okay? Now, going back to the causes of this, we have to talk about how vitamin B12 is absorbed in order to understand what can cause B12 deficiency. So first, we get our vitamin B12 mainly from our meat intake, okay? So if we eat meat in our diet, we're going to break down that meat, okay, via our saliva with amylase, which liberates the B12 from the meat, okay? Now, the saliva also produces R binder, which is known as haptocorin, okay? And what haptocorin does, or R binder, same thing, it's going to bind the B12 in order for it to survive the acidic stomach acid. Okay. Now, we're going to travel, the R binder bound to B12 travels through the duodenum, okay, and it's cleaved by pancreatic enzymes, pancreatic proteases, okay? And then, once it's cleaved by pancreatic proteases, B12 binds something known as intrinsic factor, which is produced by gastric parietal cells from the stomach. Now, intrinsic factor with the B12 complex bound together is able to be absorbed at the distal ileum in order to fully get our B12 nutrition. So, any step in this process can cause B12 deficiency. So let's take a step back. Let's say a patient has pernicious anemia. Pernicious anemia is just an autoimmune destruction of cells, okay, that attack the parietal cells, okay? This leads to a decrease in production of intrinsic factor. And since intrinsic factor is no longer going to be released due to the autoimmune destruction of the parietal cells, we get an overall decrease in B12 absorption because B12 cannot be absorbed at the distal ileum unless it's bound to our intrinsic factor. So that's one way that they can ask the question. Another way that they can ask B12 deficiency cause is if the patient comes in and they had an ileal resection, okay? So they took out the ileum. That means that that's the location of the B12 absorption. If it's gone, then we're going to have an increased risk of B12 deficiency. Okay, so those are two of the main ways that we can have B12 deficiency. And then a third way is that if we have pancreatic insufficiency. As we said before, R binder or haptocorin binds our B12 so that it can survive through the stomach. However, it has to be cleaved by pancreatic enzymes in order for it to bind intrinsic factor. If it's not cleaved, it will stay bound to R binder and haptocorin, and it's just going to be pooped out at the end of the day. All right? So, once again, those symptoms are going to be neurological for B12, so we have to worry about it. Now, what you need to do is that if a patient comes in with macrocytic anemia, so a patient has MCV greater than 100, you have to check both neurological symptoms, okay, and the peripheral blood smear in order to see, okay? Now, the reason is that if a patient comes in and you notice that they have megaloblastic macrocytic anemia and you give them B9 supplementation and you send them home, well, you can cure their anemia because you're providing them with something that can help with the DNA synthesis, but you might have missed that it could have been a B12 deficiency rather than a B9 deficiency. So then the patient will come back with irreversible neurological deficits, and they're out of luck. So very, very important to understand that. If a patient comes in with macrocytic anemia, you got to make sure that it's not B12. Okay, don't give them B9 and send them home because you can miss the neurological symptoms, which can present later on. Okay.